How's it going, guys? We have a past little question for hypertension, cardiovascular step 1, FMIM2CK. 7-year-old woman, she's got a 20-year history of, you never guess it, hypertension, managed with hydrochlorothiazide. 2 months ago, blood pressure 145/80, today 190 over 100, and eye examination shows AV nicking. You need to memorize that this just means hypertensive retinopathy. It's just a finding you see. Talk about it in my ophthalmology PDF. Left carotid bruit is heard, which ophthalmologically explanation for these findings. Let's just hop through. Choice A. Constant and wrong fucking answer. This is an aldosterone secreting tumor, zona glomerulosa of the adrenal cortex. So this would be a situation where you got classically high sodium, low potassium, high bicarbonate, high pH. Lengthy discussion, okay? But when we talk about high aldosterone, you need to be vigilant for electrolytes in the question. There can be variations. Sometimes sodium can be normal. If you've been following my content, I've talked about that. Point is, wrong fucking answer. Choice B, Cushing's syndrome, wrong fucking answer. Literally 0 in this question reflects Cushing's syndrome. Okay, you talk about very buzzy things like buffalo hump, purple striae, moon faces. You got to know as well, you can get osteonecrosis of the femoral head and osteoporosis, lytic lesions. Sorry, not lytic lesions. The fuck am I saying? Lytic lesions can mean metastases, unrelated. Compression fractures of the vertebrae. Okay, compression fractures are synonymous with osteoporosis on USMLE. So they give you a patient who has purple striae. They'll say there's compression fractures. Students confused. It's just osteoporosis due to Cushing. Glucocorticoids cause osteoporosis. Wrong fucking answer. Choice C, essential hypertension, wrong fucking answer. So this is arguably the only tricky part of this situation. Essential hypertension means idiopathic hypertension. It means patient generally over the age of 50 who is not overweight, who has high blood pressure. Increased BMI is the most common cause of hypertension. If they ask you lifestyle modification that will most decrease blood pressure, weight loss eclipses smoking cessation for patients who have high BMI. Okay, it's very important you know that, especially for all the population health stuff. Okay, but let's say you got a patient who's 55, normal BMI, and just otherwise healthy, but blood pressure is elevated on 2 separate occasions. That's essential hypertension. So a mechanism for USMLE I've seen in NBME questions, they want you to know decreased vascular compliance occurs with age. That's proposed mechanism. Stiffer vessels over time. Wrong fucking answer. Choice D, Pheochromocytoma, wrong fucking answer. So adrenal medullary tumors creating catecholamines, norepinephrine, epinephrine. So you could get it tripped up here because this causes what's referred to as paroxysmal, means comes and goes, paroxysmal hypertension. So palpitations, headaches. So you could say, well, blood pressure wasn't crazy elevated 2 months ago, and now it's super elevated. So maybe that's the paroxysmal element. It's not what we want to get at here. Okay, I'll explain the final answer. But pheochromocytoma, you're going to treat with alpha blockade, phenoxybenzamine, irreversible alpha-1 blocker. Wrong fucking answer. Choice C. And I'll just say that you're going to do urinary/serum metanephrines as the first step for diagnosing pheochromocytoma. As I already said, wrong fucking answer. Choice C, renal artery stenosis, correct answer. I've made YouTube clips on this before. Okay, if you've been going through all my content, you'll say, Mike, you made a clip on this like 300 questions ago. Probably. Okay, because you need to know ultra high yield that what is a carotid bruit? What does that mean? That's atherosclerosis in one of the carotids. Well, what caused atherosclerosis in the carotid arteries? It's hypertension above all else. Gone through my PDFs? Yes, I've talked about how in general, diabetes, smoking, hypertension in that order are the most acceleratory risk factors for atherosclerosis when we talk about locations other than the carotids. So abdominal aorta, coronaries, popliteals, okay? Diabetes, smoking, hypertension. But when we talk about the carotids specifically, it's hypertension that's the biggest risk factor because you have the strong systolic impulse pounding the carotids, causing endothelial damage. get atherosclerotic development, and carotid stenosis can lead to TIA, stroke, retinal artery occlusion. Okay, it's exceedingly high yield, can go off on a big 2CK step 3 discussion, management of all that stuff. But the point is, and this is connecting the dots, not dramatic. If you have atherosclerosis in one location, i.e. the carotids, isn't it safe to say we probably have atherosclerosis in other locations too? So the patient has a 20-year history of hypertension, chicken before the egg or egg before the chicken. So 20-year history of hypertension that led to atherosclerosis around the body, including the carotids. And around the body, quote unquote, means also in the renal arteries, also in the coronaries. Okay, so in the renal arteries. And then 20 years later, that atherosclerotic development in the renal arteries has become clinical to where now we have RAS elevation that has led to a super elevation in blood pressure. Okay, so it's become clinical after 20 years, the renal artery stenosis. That's the point here. Atherosclerosis in one location means atherosclerosis in another location. They like to give you a carotid bruit as the insinuation, the implication being that you've got renal artery stenosis as the cause. So I didn't give you the electrolytes. I could have. It would be the same thing as constant. You'd see the same electrolytes because you'd have high aldosterone, wouldn't you? But I didn't want to conflate anything here. And as I just harped on, the carotid bruit, very high yield. You know the deal. I'm going to make more content. If you like my subscribe channel. Appreciate your time. That's it.